So this is my case study presentation. My rationale for patient selection was a 42-year-old male whose last cleaning was in 2019. He had moved from California, so just getting into the routine of dental care had been a little bit challenging for him. He had generalized slight periodontal disease. His calculus deposit was a 2-3, and the patient has 32 teeth. For medical history, he has a history of COVID, but no long-term effects from it. He is not currently taking any medications, which stayed consistent throughout each appointment. He uses recreational marijuana, has been treated for gum disease in the past, and no history of diabetes and no tobacco use, putting him at an ASA 1. At his initial appointment, I saw him October 14th, 2024. His blood pressure was 130/78, pulse 72, and respirations 15. He didn't have any chief complaints, just knew that he was due for a cleaning and exam. His current home care routines was brushing 2 times per day with an electric toothbrush, flossing as needed, and he had a low sugar intake. Services provided at the initial appointment: we did 4 bite wings, intraoral photos, OHI, caries risk, which was moderate, periodontal scaling by quad starting in the upper right, and there was no exam that day due to no dentist. And I also only took the 4 bite wings because that was when the server was slow and he originally wasn't going to be my case study. And here are the bite wings that are taken. As you see, the arrows are pointing to some radiographic calculus on the posteriors. There are also some composite and amalgam restorations on the posteriors, and then there's some generalized slight horizontal bone loss as well. And a breakdown of the radiographs: generalized subgingival radiographic calculus, generalized slight horizontal bone loss, number 17 is impacted, and then the history of posterior composites and amalgam restorations, as well as mandibular tori, which we will get to when I show the full CMS. Here are the intraoral images. The gingiva appears pink, generalized slight enlargement with localized moderate enlargement, and then generalized slight papillary and marginal inflammation. Plaque index: generalized moderate biofilm accumulation on the interproximal surfaces, as well as localized moderate biofilm accumulation on the mandibular anterior linguals. For the occlusal analysis, he was a bilateral class 1 angles classification. Overbite, overjet, both 1 millimeter. Crossbite, none. Midline deviation, none. And attrition, none. His initial periodontal evaluation: the color of the tissue was generalized slight hyperemia with localized moderate hyperemia around the 3rd molars. Contour was localized slight enlargement with localized moderate enlargement around the mandibular anteriors. Consistency and texture was generalized slight edematous. Bleeding was generalized slight spontaneous. RBL and interproximal CAL, generalized slight horizontal bone loss. Statement of inflammation was generalized slight papillary and marginal inflammation, and then again the deposit evaluation being a 2-3. Looking at his periodontal chart at the initial appointment: 31 4+ millimeter pockets, bleeding spots 37, no mobility, mandibular anteriors I did not chart due to the calculus, and I think now I would be able to get a good reading just knowing how to probe around that much deposit, but just seeing him for my first appointment, I think I felt like I couldn't get it around it and get correct readings. And the original perio chart was done on paper, so I didn't have any recession or furcations noted. For the dental hygiene diagnosis: generalized stage 1 periodontitis, grade B. Microscope evaluation put him at a grade C due to seeing epithelial cells, plaque mass, spinning rods too numerous to count, gliding rods too numerous to count, cocci, white blood cells, and high mobility. Home care at this appointment: I recommended brushing 2 times per day for 2 minutes with his electric toothbrush, recommended flossing 2 times per day, and instructed in demonstrating C-shaped flossing. Treatment risk factors for this patient, putting him at moderate risk, was mandibular anterior crowding, generalized moderate dental biofilm, generalized moderate calculus, irregular dental care, generalized slight bone loss, and active decay. Treatment goals: the patient would like to get established at a dental office and start flossing more often as well. Interventions was the NSPT for the entire dentition, provide OHI instructions, and applied fluoride varnish. The expected outcomes for this would be reduction in inflammation and bleeding, reduced risk for progression of periodontal disease. Here's the treatment plan, estimating 4 appointments that included the reevaluation appointment, and then the NSPT consent that the patient signed as well. Implementation of care: technique used was hand scaling ultrasonic upper right to completion. I used Orikix, non-injectable, 1/3 of a cartridge for that. He had localized slight soft deposit and generalized moderate subgingival hard deposit. Bleeding was generalized slight spontaneous. And at his next appointment, we were going to do upper right, lower left, periodontal scaling by quad, comprehensive exam, OHI, and then complete the CMS. I saw him for a reappoint October 15th, 2024, where we did OHI, periodontal scaling in the lower right, comprehensive exam, and completed the CMS. His blood pressure that day was 132/82, pulse was 68, and respirations of 16. The patient was just seen the previous day, so the home care was just continuing the recommendations from the previous appointment. So here's the CMS that I took with the previous bite wings that were taken at the initial appointment. As you see on the anterior mandibular films, the tori that is located here, and then there are a couple restorations on the anterior laterals, some composite restorations that I also see. The comprehensive dental exam, so findings, the mandibular tori, and then restorative recommendations was number 2, OL composite, that's DHR approved due to recurrent decay. We referred for extractions of those third molars and noted 6 or 11 erosion, and the dentist that day had recommended a night guard due to the exposed dentin. Here's the dental chart, just showing those restorations that are existing, as well as number 2, being treatment plan for an OL, and the extractions of the third molars. Evaluation of the previous derided area. I had started with that upper right at the initial appointment. Bleeding with generalized moderate bleeding. Location and extent of plaque. There wasn't much, and it was kind of hard to evaluate since I just removed it the day prior. And then inflammation, same thing. Too hard to tell, if very much changed just because it was worked on the day prior. There were several remaining deposits, mostly due to not using anesthesia that day, just using the non-injectable Orikix. And then patient, too hard to tell if he was compliant with OHI, just because, again, I just saw him the day prior. Implementation of care: technique used, a hand-scaled upper right, ultrasonic and hand-scaled lower right to completion, used local anesthesia, did an IA on the right side using benzocaine topical 20%, lidocaine 2%, 1 to 100,000, using 1 cartridge. Hard and soft deposit, generalized moderate tenacious interproximal subgingival calculus, generalized moderate supracalculus on those lower anteriors, and bleeding generalized moderate. And at his next appointment, periodontal scaling by quad in the upper left, and OHI. Postoperative instructions: I had told him that he may experience some gum sensitivity and recommended warm saltwater rinsing. Also informed him that he may experience some tooth sensitivity and recommended Sensodyne toothpaste. Informed patient to brush and floss, but to be gentle. Avoid eating until the numbing wears off, just so he's not biting his cheek or his tongue, and then avoid crunchy and spicy foods. His reappoint, I saw him again on October 22nd, 2024, where we did periodontal scaling by quad, starting in the upper left, blood pressure 128/78, pulse 74, respiration 16. And patient had stated that he is flossing more, but not every day. So I recommended flossing 2 times per day, brushing 2 times per day with the toothbrush at a 45-degree angle, and instructed the C-shaped flossing again. Evaluation of the previous debrided area being the upper right and lower right, bleeding, localized slight spontaneous, location and extent of plaque with generalized slight interproximal plaque, and then inflammation, localized slight on the molars, and then remaining deposits was number 31 distal, 32 mesial, both grainy deposits. Implementation of care, technique used, hand-scaled upper right and lower right, ultrasonic and hand-scaled upper left to completion. I did a left PSA, MSA, ASA using benzocaine 20% topical, articaine 4%, 1 to 100,000, and I used 1.5 cartridges. He had generalized slight soft deposit with generalized moderate hard deposit, bleeding with generalized slight, and localized moderate around the molars. And then his next appointment, lower left periodontal scaling by quad and OHI. I saw him again on November 5th, 2024. We did periodontal scaling by quad, lower left, OHI, and then fluoride varnish. His blood pressure 128/78, pulse 70, respiration 16. Patient had stated that he was on vacation and was only brushing 1 time per day, but he has started brushing 2 times per day and flossing for the last 4 days. And home care modifications, again, just continue brushing 2 times per day and flossing. Then evaluation of the previous debrided area. I did the upper right, upper left, and lower right. It had localized slight bleeding on the lower anterior linguals. Location and extent of plaque was generalized slight plaque on the molars. Inflammation was localized slight inflammation around the third molars, and no remaining deposits. Implementation of care, I ultrasonic and hand-scaled lower left to completion. For anesthesia, I did a left IA and a left long buccal. We using benzocaine 20% topical, lidocaine 2%, 1 to 100,000, articaine 4%, 1 to 100,000 using 1 cartridge of lidocaine and a stopper's width of articaine. Hard and soft deposit with generalized moderate hard deposit with generalized slight soft deposit. Bleeding with generalized moderate bleeding when scaling, and medicaments was fluoride varnish 5%. And at his next appointment, it would be the reevaluation 4 to 12 weeks. For the completion of the NSPT, referral form was sent home with the patient. Patient was scheduled for a reevaluation appointment 4 weeks later. Gave patient referral form for the extractions of the third molars, and patient was put on a 3-month recall interval. I saw the patient for his reevaluation appointment on December 3rd, 2024, and we did the reevaluation, OHI, caries risk, which was now low, fluoride varnish, and oral photos. Medical history was reviewed, no changes per patient, vitals 128/84, pulse 72, respiration 16, and then chief complaint, none, just knew that he needed to come back in for the reevaluation, and his current home care routine / dietary habits was brushing 2 times per day, flossing 2 to 3 times per week. At his reevaluation appointment, the periodontal exam color was generalized slight hyperemia, localized moderate hyperemia around the third molars, contour localized slight enlargement with localized slight recession on the molars and premolars, consistency and texture, generalized slight edematous, and clinical assessment markers, there was none. RBL and interproximal CAL, generalized slight horizontal bone loss. The periodontal exam continued from the reevaluation appointment. The diagnosis was stage 1 periodontitis, grade B, statement of inflammation, generalized slight papillary marginal inflammation with localized moderate around 14-15 in the third molars. His deposit evaluation that day was a 1.51, and the microscope risk factor, he is a B, and that was due to seeing epithelial cells, the plaque mass, cockeye, white blood cells, few spinning rods, and moderate mobility. The reevaluation plaque index, generalized slight interproximal plaque with localized slight buccal plaque on the molars. The periodontal chart, pockets 4 millimeters or greater, there were 13. There was 11 bleeding points with some localized 1 millimeter recession on the molars and premolars, and then no mobility. Here is comparing the periodontal charts, and just see that There were several pockets that no longer were 4 millimeters or greater, and then a lot less bleeding as well. Home care instructions: brushing 2 times per day, flossing at least 1 time per day, but aim for 2 times per day. Use a water pick, as the patient stated that he had just gotten a water pick. And then demonstrated the use of an end tuft brush just to access the posterior interproximals and around those third molars, since that's where most of the plaque was being formed. The treatment plan for this was just a 1 appointment reevaluation appointment. Implementation of care: technique use hand-sealed ultrasonic and polish entire dentition to completion. Generalized slight soft deposit with localized hard deposit on the posteriors. Bleeding was localized slight around the third molars. Medicaments: 5% fluoride varnish. And his next appointment was going to be a 3-month recall for periodontal maintenance or the number 2 OL composite. Referral, supportive treatment, and prognosis. With consistent home care and regular dental care, the patient is likely to have a good prognosis for entire dentition. The patient was put on a 3-month recall to continually monitor the condition of the periodontum, and patient has been referred out for the extractions of the third molars. My reflection: the patient I provided care for presented with slight periodontitis and demonstrated a strong interest in improving his overall oral health. Although he had previously struggled with integrating flossing into his daily routine, he has recently begun flossing more consistently and has invested in a water pick with the intentions of using it regularly. This assignment was both challenging and highly educational. It was rewarding to work with a patient who was generally motivated to improve his oral health, as not all patients exhibit that level of engagement. With continued improvement in his home care routine and adherence to a consistent 3-month recall schedule, I am confident that this patient will be able to maintain his entire dentition, excluding the already recommended extractions of the third molars, for many years to come.